Welcome to Pathology Central Key Concepts. The topic of this video is carcinoma of the cervix. Now, I actually think this is a fairly complicated topic because there is a wealth of terminology and different precursor lesions. So I'm going to take you through this step by step to make sure you completely understand this lesion. So with that in mind, I'm going to be focusing the majority of this talk on the pathophysiology and morphologic findings of cervical squamous cell carcinoma and its precursor lesions. I will also briefly discuss adenocarcinoma of the cervix. So about 70 to 80% of cervical carcinomas are squamous cell carcinomas, with about 15 to 25% being adenocarcinomas. And back in the 30s and 40s, cervical cancer was a leading cause of death in American women. By the 1950s, cervical screening had become quite widespread in the United States, and by the 1990s, cervical cancer incidence and mortality had dropped about 60%, and currently cervical cancer is the 13th cause of cancer mortality in American women. So this has been a dramatic decrease, and what that tells you is that we have an incredible screening system. And this is, of course, the Papanicolaou or Pap test. And what Dr. Papanicolaou discovered in 1928 is that if he looked at cells that were exfoliated from women who had cervical or vaginal malignancies or precursor lesions, he could detect this cytologic atypia and thereby diagnose early stage disease. So this is just an example of what we see on a Pap test. Here in panel A, we have the healthy appearance of squamous cells from the cervix. They can be either blue or pink. That doesn't have any particular bearing on malignancy. And you can see like squames that you would see of the skin. There's abundant cytoplasm. The cells are somewhat flat with a very small nucleus here. Now what we see here is what we would call mild dysplasia or low-grade squamous intraepithelial lesion, and I'll talk more about that terminology in a moment. And what you can see here in contrast to the healthy squamous cells is that we have enlargement of the nuclei. They're also hyperchromatic, and you can appreciate it probably best here. There's this clearing around the nucleus, this perinuclear halo. This particular nucleus even has a multilobated appearance to it. Now, as we go to higher grades, we can see here that we get increasing size of the nucleus in proportion to the cytoplasm. In fact, by the time we get to high-grade dysplasia, we have barely any cytoplasm left at all. Here you can appreciate the clumpiness of this chromatin. And here you can see this somewhat raisonoid or folded appearance, these wrinkled nuclear membranes. So this brings us to a discussion of precursor lesions. So these precursor lesions tend to peak at about the age of 30 years, about 15 years before invasive carcinoma, because without treatment over those 15 years, we'll get the addition of additional mutations. So the way that we categorize this is using two types of terminology. We have squamous intraepithelial lesion, or SIL, which is a two-tier system, which we call just high grade or low grade. And then we have cervical intraepithelial neoplasia, or CIN. This is similar to what we will see in other organ systems. For example, pancreatic intraepithelial neoplasia is PAN-IN. Prostatic intraepithelial neoplasia is PIN or PIN. And this is going to be a three-tier system. We have CIN 1, 2, and 3, corresponding to mildly, moderately, and poorly differentiated lesions. So let's take a look at the differences between these two, and I'll explain why we have both a two-tier and a three-tier system. So low-grade squamous intraepithelial lesion corresponds to CIN1, or well-differentiated. And when a patient has this diagnosis, we know that most cases will regress and a small number will progress to malignancy. What is occurring in these cells is that we have a high level of virus replication with very mild alterations in the host cells. And because most of these cases regress, it is much more common than high-grade squamous intraepithelial lesion. Now, high-grade SIL corresponds to CIN2 and CIN3 and has a higher risk of progression to malignancy. What we see in these cells is that we have increased deregulation of the cell cycle, decreasing maturation, and decreasing viral replication. I'll explain why we see that in a moment. Now, while most H-cell develop from L-cell, about 20% develop de novo. So what this tells us is that if we are able to recognize L-cell and treat patients appropriately, we can prevent this progression to H-cell and malignancy. So why do we have these two systems? And the reason is that clinical management is primarily two-tier. So if a patient has low-grade squamous intraepithelial lesion or CIN1, since we know that the majority of these cases will regress, we will typically just observe the patient with frequent Pap tests, perhaps colposcopy and biopsy. However, with high-grade squamous intraepithelial lesion, or CIN2 or CIN3, we're going to move typically towards treatment. And that treatment is going to be, for example, cone biopsy, a loop electrosurgical procedure, or LEAP, or cryotherapy. And both cone biopsy and LEAP will involve cutting out a cone of tissue from the cervix. So why do we have a three-tier system? Why don't we just leave it as two-tier? And that's because three-tier systems can be useful for the clinical decision-making for younger patients. And depending on the study, this can be patients who are less than 25 to less than 30 years old. Now keep in mind that because we have this gradation of dysplasia, that CIN2 will have a higher regression rate than CIN3. So if you're trying to make the decision between observation and treatment, you need to think about what your patient's long-term goals are. Does this patient wish to have a subsequent pregnancy? The reason this becomes important is because with LEAP or cone biopsy, we have an increased risk of preterm delivery. For females who are not anticipating a future pregnancy, you may wish to go directly to treatment if that's what the patient wishes. So the pathogenesis of cervical carcinomas is very, very interesting, and you've already encountered some of this in the neoplasia chapter of Robbins. So high-risk human papillomavirus or HPV infection is seen in 99.7% of cervical cancers. So this is a really strong driving factor. Now, as you'll recall, we categorize HPV into two types, high oncogenic risk and low oncogenic risk. And there are multiple types of HPV. The ones we most commonly think about with high oncogenic risk will be type 16 and 18. And in fact, these are associated with about 70% of cervical intraepithelial neoplasia and cervical carcinoma. We can also see these HPV types associated with squamous cell carcinoma of other areas, and I've listed some of them here. By contrast, our low oncogenic risk HPV, for example, type 6 and 11, can be associated with non-malignant proliferation such as condyloma acuminatum. Now, HPV infection is an extremely common infection that tends to peak at the age of 20 to 24. It is a sexually transmitted infection, and most infections are transient and are cleared by the immune system. The duration of infection is going to relate to whether it is a high-risk or low-risk HPV type, with high-risk HPV being more prone to have a longer infection. And we know that about 80% of low-grade precursor lesions and 100% of high-grade precursor lesions are associated with our high-risk HPV types. And this is going to provide the basis for the HPV vaccine as well as for HPV testing. So, what is necessary to have persistent infection? So first we need to get viral entry into the cell. And the cells prefer to infect immature basal epithelial cells. So these can be exposed due to trauma or more commonly we will see it with squamous metaplasia at the transformation zone, which I'll cover in a moment. But even though the virus will enter immature basal epithelial cells, it can't replicate there. It needs to be in a maturing squamous cell. Now, our maturing squamous cells are usually in G1 phase, so the virus has to hijack the machinery of the squamous cell to put it into the ideal conditions for it to replicate. We see persistent infection increases risk of precursor lesions and carcinoma. So let's talk now about the squamous metaplasia at the transformation zone. So here you can see a beautiful section that shows endocervical mucosa here with the columnar glandular cells we associate with that. We have our mature squamous cells here of the ectocervix. And then what happens at puberty is that due to hormonal influences, we're going to get the endocervical glands are going to, this mucosa is going to move towards the ectocervix. And when these glandular cells experience the pH and other conditions in the vagina, they will undergo squamous metaplasia. So these are these immature squamous cells that have increased susceptibility to HPV infection. So if you correlate this, so this is occurring at puberty, and this is a sexually transmitted infection, so increased sexual activity occurs typically after puberty. So this is sort of setting this up for the infection by HPV. So how does HPV actually cause cancer? So again, this is covered very well in the neoplasia section of Robbins. I'm going to go over it here again as well. So there are two proteins that are extremely important. One is the E6 protein and the other is the E7. Now the viral E6 protein is going to bind and degrade P53, and one of the reasons why we believe that the high-risk HPV drives towards cancer, whereas the low-risk HPV does not, is that high-risk HPV has a higher affinity for P53. A second action of E6 protein is to stimulate expression of TERT, which is the catalytic subunit of telomerase. This can drive us towards immortalization. Now the second protein is a viral E7 protein, and what it will bind to is RB. And again, high-risk HPV has a greater affinity for RB than what we see with low-risk HPV. And when the E7 protein binds RB, it's going to cause release of the E2F transcription factors, which will drive through the cell cycle. The other action of viral E7 is to inactivate the cyclin-dependent kinase inhibitor P21. Now remember, it is our cyclin-dependent kinases and our cyclins that drive us through the cell cycle. So when we remove this inhibition, that's going to further drive the cell cycle progression. And then the final component is that we can get viral integration into the host genome. And this again occurs more commonly with high-risk subtypes than low-risk. The low-risk types tend to remain in episomes in the cytoplasm. And with this viral integration, we get increased expression of E6 and E7, as well as increased genomic instability. And this combination of increased genomic instability with loss of P53, our guardian of the genome, is going to contribute to our oncogenesis. Now, I'm going to take everything I just told you here and show you in a figure. This is from Robbins and Kumar Basic Pathology, and I think it really puts together nicely. So we have our HPV E6 protein, which is going to act here on TERT, increasing our telomerase expression, driving us towards immortalization. E6 is also going to bind to P53 and degrade it, and this is going to lead to increased genomic instability. The E7 protein is going to bind RB, freeing up our E2F, which is going to promote transcriptional activation and cell cycle progression. And E7 also will inhibit P21, which is going to increase our cyclin-dependent kinase 4 and cyclin D activity, leading to cell cycle progression. So this is going to take us to our increased cell proliferation. So what do we see? We've already looked at the Pap test. Now we're going to look at some histology. So the characteristic finding is going to be nuclear atypia. Now this is going to be a low-grade squamous intraepithelial lesion, or CIN1. And what we see here is enlargement of the nuclei. So you can see here, this is going to increase our nucleus to cytoplasm ratio. The nuclei are very dark. You can compare these hyperchromatic nuclei to some of the lighter ones over here. The chromatin is going to be somewhat coarse and clumpy, and we're going to see this pleomorphism, so this variation in size and shape across these different cells. The cells will have a somewhat wrinkled or raisonoid appearance, and in fact we can see here, this used to be referred to as multinucleation. We now know this is actually multilobation, so this is a single nucleus which has a very convoluted contour. And this combination of this convoluted raisonoid appearance with this perinuclear halo is referred to as coilocytic change or coilocytosis. And we tend to see that in our low-grade lesions. And I'm going to show you some really nice images in a moment. So how do we grade our squamous dysplasia? So it's going to depend on whether these immature squamous cells with these atypia are confined to the lower third of the epithelium, which would be considered L-sil or CIN1. The lower 2/3 will be H-sil and CIN2, and full thickness will also be H-sil and CIN3. So let's take a look at this histology. So here you can see a healthy ectocervical mucosa with maturation of our squamous cells. By contrast, in this L-sil or CIN1, you can see that we have proliferation that is coming up above the basal layer. You can also appreciate here this coilocytic change. In this moderately differentiated squamous dysplasia, or CIN2, you can see that the proliferation now is extending up above the third, up to the upper 2/3. There's still a little bit of coilocytosis here, which we lose when we move to our CIN3, or poorly differentiated squamous dysplasia. This actually, if you were to take this epithelium and flip it upside down, it's really not apparent which is the top and which is the bottom, because we have immature cells extending the full thickness. And this is something we would describe perhaps as carcinoma in situ. Now, I've already showed you the Pap test, but I think it's nice again to do the compare and contrast, showing our coilocytic change here and here. These enlarged nuclei with a smaller cytoplasm, which you can appreciate here. And then when we get to this very high-grade dysplasia, you can see we have minimal cytoplasm. The cells are very primitive, and you can see that they're very immature. Now, what is going on in these cells? Let's remember again, this is looking at some low-grade squamous dysplasia. So this is our coilocytosis. Now remember, the HPV is going to infect in the basal cells, but it's going to proliferate in those maturing squamous cells. So if we do a stain for HPV DNA, it's going to be in the upper portion of this epithelium. But what we're going to see if we look at our proliferation marker is that we have proliferation the full thickness. And this will be even more marked if we were to look at a severe dysplasia. So what are the risk factors for cervical carcinoma? So we have both HPV-related and non-HPV-related risk factors. So the HPV-related risk factors include early onset of sexual activity. Remember, at puberty, we're going to have exposure of that squamous metaplasia. Multiple sexual partners, because it increases the risk that one of those partners will have HPV. High-risk sexual partners will be partners who also have multiple sexual partners or who have a history of STIs. And a history of STIs is also a risk factor for cervical carcinoma. And then an important consideration is immunosuppression. Now remember, I mentioned that most low-grade squamous intraepithelial lesions will be cleared by the immune system. If you have a patient who is immunosuppressed, perhaps someone who has got an autoimmune disease, who's taking steroids, or an individual who's immunocompromised due to HIV infection, these individuals are at increased risk for cervical carcinoma. And finally, we have some risk factors that are not related to HPV, such as cigarette smoking. Lower socioeconomic status is believed to be due to access to care and appropriate screening. And it's not clear why oral contraceptive use is a risk factor. It has been thought that oral contraceptive use means that individuals are less likely to use a barrier method, but it appears there may be some other contributions to this as well. So this brings us, now that we've discussed our precursor lesions, to cervical squamous cell carcinoma. So as I mentioned, this is going to occur in a slightly older age group, so 40 to 50 years old. And as I mentioned before, this is going to account for about 70 to 80% of cervical carcinomas. HPV 16 is the etiologic factor in about 60% of cases, whereas HPV 18 is much less commonly involved. And you're going to see that this is different from what we will see with adenocarcinoma of the cervix. Now, most patients with cervical squamous cell carcinoma are asymptomatic. That's why Pap testing is such a critical screening device, because patients, because they'll be asymptomatic, can present with very late stage disease, and prognosis is going to be very tightly correlated with stage. So grossly, what we can see is either a fungating exophytic mass or an ulcerated or infiltrating mass. And as we get infiltration into the cervical stroma, we can get thickening of the cervix to what is called a barrel cervix. And with extensive disease, the cervix may become fixed. Histologically, we may see either keratinizing or non-keratinizing invasive squamous cells. So let's take a look at our growths first. So here you can see this is a hysterectomy specimen. This is the ectocervix. And here on this lip, you can see this roughened lesion here on the ectocervix. Now, histologically, I think this is a beautiful example. This is showing what was an in situ carcinoma, where it has just now broken through the basement membrane to become an invasive squamous cell carcinoma. And we can recognize the squamous differentiation by this abundant eosinophilic cytoplasm. Now here's another image from the textbook showing an invasive squamous cell carcinoma. Basically this could be arising anywhere. This looks like pretty much any squamous cell carcinoma. We have some keratin here. Let's take a look at a lesion that I think is a little bit more suggestive of a cervical primary. So in this lesion, you can see these nests. This is a moderately differentiated squamous cell carcinoma of the cervix. And I think what clues me into the HPV association is that we can see these perinuclear halos here, a little bit of wrinkling and raisonoid appearance to the nuclei, and elsewhere in the specimen there was some multilobation. So that combined with the site, which was the cervix, takes you to seeing that HPV association. Now finally, I'd like to just finish up by briefly discussing cervical adenocarcinoma. As I mentioned, it's much less common than squamous cell carcinoma. When we began with Pap screening, this greatly decreased the incidence of squamous cell carcinoma, but because the Pap test is not as good at identifying cervical adenocarcinoma, we had an increased proportion of diagnosed malignancies were adenocarcinomas. However, now that we have HPV vaccination, the levels of both of these are decreasing, and it will remain to be seen how these end up in their various proportions. As I mentioned, HPV 18 is more commonly associated with cervical adenocarcinoma, and the appearance can look very similar grossly to what we see with a squamous cell carcinoma, with either an exophytic or ulcerated lesion, may also form a barrel cervix. In contrast to what we see with squamous cell carcinoma, we're going to see invasive glands. And as we saw with squamous cell carcinoma, the presentation is that patients are usually asymptomatic. So again, they can present at very high stage disease, which is going to have an impact on their prognosis. Very rarely we can see atypical glandular cells on the Pap test, but it is suboptimal and much less sensitive than what we see for squamous cell carcinoma. Histologically, here's just a nice example of an invasive adenocarcinoma of the cervix. We know the location here by looking at the stroma. This is the typical cervical stroma. And we can see these atypical architectural features. This is cribriforming or glands within a gland that help us to recognize these are malignant glands. So before we finish up, I'd like to talk a little bit about cervical cancer screening and prevention. So as you've already recognized, the Papa-Nicolau test has had a huge impact on women's health in this country. We have a complementary test that we can do, which is a test for HPV DNA in cervical scrapes. This is going to be most useful in females greater than 30 years because when we look at younger females who have a higher incidence of this infection, very often that will be cleared. So using testing for HPV DNA is more commonly used in older patients. With the HPV vaccine, we have decreased cervical cancer rates, but that does not mean that we should avoid our Papa-Nicolau testing because not all of the HPV types are covered by the HPV vaccine. So we need to continue to monitor this. And just a point I'd like to make is that while the Papa-Nicolau test has had a tremendous impact in higher resource countries, we still see that cervical cancer cases and deaths are very high in low and middle income countries. So about 90% of these cases and deaths occur in low and middle income countries. So there are some opportunities for global health issues there. And finally, I'd like to just finish up with some questions so you can review the material that I've covered. As always, thank you very much for your time and attention. I hope you have found this useful.